This is Health Broadcasting Service, HBS Radios, your global pioneers in specialist radio broadcasting, bringing you everything to enhance your health and well-being. Health is your human right. HBS, your partners in everything about your health and well-being.
Hello and welcome to In Conversation With, podcast by The Lancet Public Health. It's February 2024 and my name's Jonathan Blott. In this month's episode, I'm joined by Marin Zhelev from the University of Vienna. Dr. Zhelev is the first author of a new review on cancer risk factors and access to cancer prevention services for people experiencing homelessness. Let's start with some background to this review. So, for example, how does the rate of cancer in people experiencing homelessness differ from that of the housed population? And can you also tell us what the aims of your review were?
Sure. So the background of this review is that studies from different country contexts found a higher incidence of cancer and higher cancer mortality rates in people who are homeless than in people who are housed. So people who are homeless face a higher risk of developing cancer, lower rates of cancer screening, and therefore also later stage diagnosis and higher risk of dying of cancer. And while people who are homeless are more exposed to cancer-associated risk factors, there is a lack of awareness and structures for targeted cancer prevention. Regarding your question about the aim of this review, the aim was twofold. Firstly, to map the available evidence on exposure to cancer risk factors, for example, smoking, alcohol addiction, or sun exposure. And secondly, to synthesize barriers and facilitators to accessing cancer screening. So we considered these questions as relevant because they can form a basis for the development of prevention measures targeted at people experiencing homelessness.
And you looked at 40 studies on homelessness and cancer and identified that the barriers to services broadly exist on 4 different levels. So these are the individual, interpersonal, system, and policy levels. So what were the most significant findings or trends in these studies regarding the cancer risk factors and barriers to services? And so perhaps you could tell us a little bit about each level?
Yeah, sure. So regarding the first question regarding the cancer risk factors, the study results showed that people who are homeless are highly exposed to certain cancer risk factors. And the most common factor that we found in these studies were tobacco use, ranging up to 74%. And this is a very high number compared with population survey data. And regarding the factors determining the access to cancer prevention services, these concern, as you said, many different levels. And I think it makes sense to give one example of each level. At the individual level, we found, for example, how psychological and physical factors influenced the screening uptake. Having had a history of sexual trauma influenced the overall screening experience of women, and intentions to do a pap test because it can, of course, be a trigger for re-traumatization. So women who had suffered sexual trauma were afraid of being touched, thought it was a painful procedure, and were often very afraid of the pap test procedure. Conversely, and this brings me to the next level, the interpersonal level, sexually traumatized women who were homeless were willing to have a pap test if they had a trusting relationship with their healthcare provider and received empathetic and sensitive care. So the social competence of the healthcare provider and their staff is very key. So being trustworthy, empathetic, and non-judgmental is very important to create a safe environment for these screenings. Further studies found that it was important to explain the screening procedure thoroughly, and this is, of course, linked to taking the time to engaging with people who are homeless, like, for example, explaining what will happen during the test, following up on how the person is doing after the test, and also explaining the results and providing a lot of support in case of positive results. Because, of course, people who are homeless are often lonely and lack support. And for them, a positive result might be related to lack of money and resources to undergo treatments. On the system level, lack of privacy in shelters were reported as barriers to colorectal cancer screening. This is because toilets in the shelters are often not private, which makes it difficult, of course, to prepare for colonoscopy. Another important factor to obtaining preventive services was regular access to healthcare services. This may be a very obvious point, but it is a very critical one also because it's known from previous studies that people who are homeless face difficulties in accessing healthcare services, and they often feel discriminated by healthcare staff. So seeking regular care at the primary care provider is important, but it's also important that the healthcare providers also use this opportunity of contact with people who experience homelessness to make them aware of the importance of cancer prevention and also check their screening status. I'd like to link this point to our preliminary qualitative findings from our EU project Cancerless. There we found that the common preconception that people experiencing homelessness do not care about their health is actually not true, because people experiencing homelessness do care a lot about their health, and they do find it very important. Some are also so scared to talk about cancer that you cannot even use the term when speaking about it. So you also mentioned the policy level and interventions to facilitate access to cancer prevention. It is important to sensitize medical staff who are used to providing outpatient care to people experiencing homelessness to the importance of providing preventive services to them as well. Navigation programs resulted as important. So navigators who facilitate health education, help with scheduling appointments, send reminders to patients so that they can, or that they also keep their appointments, or to accompany them to the doctor. This was found to be important. And also a holistic approach would be necessary by tackling primary and secondary cancer prevention, for example, skin education and better access to dermatological care.
Considering all of these barriers, and you have touched upon a few of the recommendations there, but could you give some other examples of what kind of things you think could be done to improve access in this population? So these low threshold interventions that you mentioned in your paper, and what other kinds of changes could we expect at the policy level?
Cancer screenings are a multi-stage process and implies to have regular uptake from a certain age on. It implies preparation, following up on test results, and taking the necessary steps when there is a positive result. So the question is, how do people remain involved in this whole process? And achieving this is associated with health education in a language that the person understands. So this can mean speaking in the person's native language, but also in very simple terms or in lay terms so that the people understand. And of course, as I already mentioned, building a trusting relationship and explaining each step of the screening procedure thoroughly. And I mentioned it before, navigation programs that are tailored to people who are homeless are important. And I can give you a very specific example of what that entails from our EU-funded research project, Cancerless. We work with specially trained navigators. They offer support by in-person meetings, which are integrated at local partner organizations. And these organizations are easily accessible for people experiencing homelessness. And most importantly, people trust in these services. The navigators there take a lot of time for listening to people who are homeless. They provide and explain information on cancer prevention. As I said, they help scheduling appointments, for example, with their gynecologist, or they also make reminder calls. They sometimes accompany them to the doctor's appointments in case there is a lack of family support or when people fear going there alone. But it's also about empowering people to do all that themselves. It really depends on the person and adjusting to their specific needs. So in terms of primary cancer prevention, navigators can also help in connecting people experiencing homelessness with smoking cessation programs or sport classes free of charge, and in general raising cancer awareness. So it's really about bringing together primary and secondary cancer prevention. And low thresholds interventions in general can increase the uptake of care because they remove many barriers to medical care, such as people do not need to make appointments beforehand. They are easily accessible. There is a non-judgmental attitude of health staff, and people, most importantly, feel safe there. So these social aspects are very important in this context.
And just to look at some of the limitations to these studies. So most of your included studies were done in the US. So how might this affect your findings, and what other research gaps and study limitations were there?
Yeah. So cancer prevention services are, of course, context dependent, and they depend, of course, on the system, and the systems might vary. So the questions are, to what extent are shelters able to provide healthcare or are connected to healthcare facilities? Or to what extent does the public health system provide free prevention services? And how is the awareness of cancer prevention as a priority in general? All this varies, of course, according to the setting. And as you said, the most of the studies that we included and most of the findings that we reported in this review were specific to the US context. So there is little evidence from non-US settings. So, of course, to account for these differences, more studies are needed from other countries and continents. The main limitation was regarding the reporting of the prevalence of cancer risk factors. There was a scarcity of studies focusing on the connections between cancer risk factors and cancer in people who are homeless, and comparing the prevalence of cancer risk factors between people who are homeless and people who are housed. So this was a main limitation, and there is more research necessary in this area. Another point that I would like to make is that homelessness can manifest in many different forms, so it's complex and dynamic. It can occur in people who are living rough, people live under threat of violence, or people living in extreme overcrowding and so on. And homelessness can be a temporary situation, but it can be episodically, or people are chronically homeless. And we were not able to take these differences into account with regard to differential access to cancer prevention.
And finally, what would you like to see from future studies in this area?
It would be desirable to see the introduction of screening services at places where people experiencing homelessness access care and providing them with the support they need. At the policy level, interventions should focus on advancing knowledge of healthcare staff on the relationship of health and homelessness, and improving the coordination of services and their flexibility. And very importantly, we should not forget that we are writing and talking about a vulnerable group, and their voices need to be included too. So it's important that they participate in developing interventions so that their needs, but also how they adapt to their circumstances, can be understood properly. And they should be involved in co-developing solutions to mitigate barriers that they face and to make these solutions more sustainable.
Dr. Maren Jalef, thank you.
Thank you very much.
I'd like to say a huge thank you to Maren Jalef, and thank you for listening to this episode of In Conversation with The Lancet Public Health. The study we discussed is available online at thelancet.com. Please remember that In Conversation with The Lancet Public Health is available wherever you usually get your podcasts.